Christopher Dubel. This is not the first time Mr. Dubel has joined us for the symposium, and we are delighted to have him return to us this year. Mr. Dubel is Director of Training and Director of the Institute on Protective Services at Temple University. The Institute on Protective Services at Temple University Harrisburg is funded by the Pennsylvania Department on Aging. They provide training and consultation to Pennsylvania's protective services, network, law enforcement, and allied professionals on how to recognize and respond to cases of elder victimization. In addition to managing their program at Temple Harrisburg, Mr. Dubel has been public speaking professionally for over 20 years. Topics include dealing with stress in the workplace, engaging, motivating, and retraining staff, particularly ethics for human service, civil investigations, grief, loss, and addressing victimization of older adults and adults with disabilities. His strength as a trainer are engaged particularly in practical content and the use of laughter to learn. Prior to his current role as Director of Training, he has been on the social works faculty at Temple University Harrisburg, managed a care coordination at Penn State Hershey Medical Center, and a direct practice social worker in a number of different fields. So we'd like to thank Mr. Dubel for today's guest appearance, and I'm going to hand it over to him.
Great. Good afternoon, everybody. Can you hear me okay? If you can hear me okay, just shoot me a chat in the chat box to let me know that. Last spring, thank you, Leah and Dawn. Last spring, I was doing one of my first I have been training a long time, but I am new to this virtual platform. And so it was March or April, I was doing a training for the International Chiefs of Police Association. And I rocked the introduction. I just nailed it. For 10 minutes, I was going strong. And I got to that first point of interaction, and I asked a question, and it was crickets. I had been on mute the entire 10 minutes of my introduction, and they were trying to call, the sponsors were trying to call me, but I thought it was like I didn't recognize the numbers, so I thought it was a scammer, and I didn't answer. So I am slowly getting used to it, and thank you everybody for verifying that you can hear me okay. I'm a classroom trainer. Some of you may have heard me speak already. I just love interaction. So I'm going to ask you to warm up your fingers. And I know it's the end of the day. I know you're kind of blue jeansed out here on staring at the screen. But we're going to survive this together by being interactive. So first thing I want you to do is I want you to chat at me. What's your discipline? Who are you? What's your professional background? I'm going to you'll see me look to the side because of how I have the chat box set up. But share with me. Are you social workers? Okay, thank you, Karen. In what specific field of social work, Karen? How about others? Recreational therapist and administrator, Michelle. Michelle, I think I recognize that name. I think we've met in the past. Geriatric social worker, community-based, peer specialist, home health social work. Okay, lots of social work. My colleagues in social work, children and youth currently, aging social work, hospice social work, nurse and business manager of a DSNP. Can you define DSNP for me? I feel like I should know what that is, but I don't. Attorney, thank you, Brendan. Protective Services Investigator. I love my PS investigators. Leah, you know that. Psychiatric nurse, medical social work community. Fraud investigator at the community bank, Dawn. Great. I used to teach, yeah, Michelle, I knew you from somewhere. Dual eligible special needs plan. Medicare, Medicaid is dual eligible. Okay, great. That's the first question. Now the second question is a little word association. If I say the word self-neglect or self-neglecting older adults, what are the first words that come to your head? What are the first things that come to mind for you? Depressed, depression. Okay, 2 for depression. Excellent. Poor at ADLs, activities of daily living. Dementia, apathy, forgot, depressed. Cognitive issues, maybe. Yeah, staying in their home despite not being safe. Absolutely. Oh, Margaret. Now, I should have said this beforehand. I'm going to interact with you, and you have permission to unmute yourself and jump in for a little bit. And if I see something that I don't quite get, I might ask you to unmute. If you don't want to unmute and you don't want to speak up, just tell me, Chris, I'm not unmuting myself. But Margaret, I'm really curious about what you meant by gave up. And if you're willing to unmute and share what you mean by gave up, that would be great. If not, that's okay.
Chris, I think I meant that, well, I actually know what I mean. I think it's you see an elderly person who has just felt like kind of beaten up by life and they can't handle their ADLs anymore. They can't handle their bills. They just are kind of in this state of, I don't know what to do anymore. I'm just kind of
Yeah.
here.
And Margaret, what was your professional background again?
I'm a AAA supervisor.
Okay. And is there, and without breaking any confidentiality, is there a case that kind of resonates with you where you saw that?
Well, I always think of this one woman when the AAA's did the waiver program, and I used to go out and visit her, as we were needed to, and then as she needed me to. And she was just very, very sick and bedbound, and you could just tell by the light in her eye or the lack of light in her eye that she was a burden on her family and the care level that she needed. And we just had a really difficult time trying to get her to smile sometimes, but she was a lovely lady, but it was just, I felt like the light in her eye had left. And she wasn't anywhere near that end stage of anything. She was just in the middle of this bedbound phase of her poor life,
Yeah, I like how you put that, and thank you for being willing to unmute. Just kind of that light, the light in their eye has gone out, that feeling of hopelessness. I think we see that a lot with self-neglect clients, consumers, whatever, patients, whatever the name is in your field. I want to grab a few more. Hoarding, poor living conditions, poor decision making, absolutely. Self-will versus oh, Nicole, you can't throw something out at me like that without unmuting. Nicole, what do you mean by self-will versus decreased competency?
Hi, I have a lot of elderly, very medically frail patients.
And what's your background again, Nicole?
I'm a medical social worker in the community.
Okay.
And so I'm in the homes with a lot of my nurse practitioners, field-based nurses, doctors, and they often want our patients to make different choices.
Yeah.
And the conversation of self-will versus decreased competency is a daily, if not every other hour conversation with my coworkers and my care team members.
Yeah. And let me give you that is so true, Nicole. And let me give you my brief background. Some of it was alluded in the introduction that my grandmother wrote and sent to the folks at the Neff Symposium. Thank you, Grandma. But I spent about 7-8 years as a hospital social worker at the Penn State Hershey Medical Center here in South Central PA. Then went and helped start the Institute on Protective Services for about 3-4 years. Then went back and managed the hospital social work department for about 3 or 4 years at Hershey. Then came back to Temple and have been there about 12, 13 years now. But we would always, I hated, and I don't remember if there's a psychologist or a psychiatrist on this call. If there is, I'm sure you were not one of the ones that did this to me at Hershey, but I hated making referrals for a psych consult or a psych assessment for individuals who would self-neglect, because every time they would come back, because they wouldn't meet criteria to be an inpatient, but every time they would come back and say, this person needs 24-hour care. And as a social worker, you're kind of going, A, that doesn't exist, and B, that level of cognitive capacity that is there. And yes, they may have some decreased executive functioning, but they can still make some decisions. We'll talk about that more. A couple others in there, staying in their home. Jennifer, I'm going to ask you if you'll jump in for me for a second. Probably thought you got away with it because I didn't get there, but I really noticed that comment of staying in their home despite not being safe. Is there kind of a case or an illustration that comes to mind when you think of that?
Not per se, but generally most older adults don't want to move, whether it's the act of moving, which is stressful for anyone,
Yes.
is it their lifelong home or where they raised their children or spent decades with their spouse?
Yeah.
And I find that there are some cases where the house had been an asset and it becomes more of a liability.
Yeah. Yeah. Tell me what you mean by that. It had been an asset, now it's more of a liability. You mean in value, or you mean in physical threat, environmental safety?
The house is too big, the
Yeah.
lawn care is too much, the house is in disrepair or
Yeah.
would cost a lot to get
Yeah.
fixed.
Yeah.
It just is overwhelming and unmanageable, whereas 40 years ago it made sense to be in that size house.
Yeah, absolutely. I appreciate that. Thank you. One more I want to hit. Alicia just jumped in here and said lifetime of poor decisions. Alicia, are you willing to unmute and just share a little bit more about what you mean by a lifetime of poor decisions?
Sure.
Thank you.
I guess one of the things that we deal with a lot, and when I have students with me, is you walk into a situation and you're getting history, you're getting background, and you're realizing that the person really hasn't made a lot of great decisions in their life, whether it be, decisions with who they decide to marry, or the way that they raise their children, or the way that they keep their home, hoarding, whatever it might be.
Right.
And a lot of times that doesn't change as they get older. So, the decisions that they now need to make about their own health are poor as well, because they just don't have the skills or the strategies to really make good decisions. And like someone said earlier, that's fine, because people have a right to make their own decisions if they are capable of making those decisions. But when you get to the point that they're no longer capable, that there is some impairment and they can't continue to make those poor decisions because now they can't even make them, they don't have the capacity to make them.
Yeah. No, that's perfectly said. And it actually transitions nicely. And I mean, one of the things that you talked about and others have talked about, Nicole talked some about, is that decreased capacity. And I always say I wish capacity was like the turkey at Thanksgiving, where when it's done, when it's incapacitated, there's a little button that pops out and goes, oh, it's incapacitated now. And we could go, okay, they're incapacitated. But all of us on this call, all of us on Blue Jeans training session know that capacity falls on this continuum. And there are times where I can go and I can talk with someone at 10 a.m. who is self-neglecting, and they may be fully capacitated to make their own decisions. But by 1:30, 2 o'clock, we're dealing with a totally different situation and story, and we'll talk some about this. This is the point in the presentation. There are it looks like there are 51 people on here. This is the point in the presentation where we go down to 27. It is the moment that I tell you that nothing in this presentation is magical. Nothing in this presentation is going to cure self-neglect. Because as you're talking about, Alicia, one of the things that I absolutely love, and I've been working with older adults pretty much since I got out of college back in 1995. So since I've been working, I love the fact that they bring with them to every situation 60, 70, 80, 90 years of history of life behavior. But it's also what makes self-neglect incredibly hard and incredibly difficult for all of us, because there is nothing that we can do in 24 hours, 48 hours, or even 2 weeks, or 6 weeks, or 8 weeks that will magically fix their self-neglect. So what I want to do today, there's kind of 3 major goals that we have for today. One is I just want to talk generally about what self-neglect is. I think most of you, based upon your background, are going to be familiar with it, but just generally what it is. And I'm also want to then talk about what needs to be part of our assessment in self-neglect. Because when it comes to self-neglect, I have become convinced that assessment and good assessment is as important, if not incredibly more important, than the intervention. Assessment is as important, if not more important, than the intervention. And what I mean by that is without good assessment, without strong understanding of what we have in front of us, A, we're not going to pick the right intervention, but B, we might also miss opportunities. Because there are and I certainly want to say that other forms of abuse that are done by a perpetrator, sometimes we have people that don't want help either. But I haven't met many older adults who are self-neglecting that come rushing up to me when I was helping with protective services or in medical social work going, Chris, you're here. I'm ready to deal with my self-neglect. I'm ready to get, clean up this entire house. That just rarely happens. More often than not, I'm looking very carefully for those very small opportunities that I can make incremental change. And that's what we're going to talk about. So the first, and we're not going to read PowerPoint slides to you. This is the National Center on Elder Abuse definition about self-neglect. There are a couple things in here that are key. The first is that it has to be self-neglecting behavior that presents a threat to our physical health, mental health, or safety. All of us self-neglect. Every single one of us self-neglects. Since COVID, I have been forgetting to put deodorant on routinely in the morning. I forget every time, and yes, I use Secret. Don't make fun of me, but I just keep forgetting. Is that self-neglect or is that abuse to the people around me? I'm not sure which, but I'm not doing it, right? But it has no consequence. It has no real significant consequence to my physical health or mental health. So when we look at self-neglect, people are allowed to make decisions that aren't the best for them, as long as it's not this serious threat. And this is where it gets sticky, and this is where it gets tough. Because I also like a good bag of Grandma Utz's potato chips. And when I say a bag, I don't mean one of those little small, lunch type. I mean like the big old bags. And you stick one in front of me, and I'm going to keep eating those chips over till that bag is almost done. I can literally eat a bag in a second. I got to say, there's probably some stuff going on that I'm going to pay for later. So it becomes really, and again, this is where we'll talk a lot about assessment. It becomes tough to assess what is the level of risk to somebody in a particular situation. Certainly when we go in and somebody is smoking with oxygen with newspapers piled up from 1953, we have a pretty good sense of the risk. But what if they're just missing 3 or 4 doses of their antipsychotic medication, once a month? Is that a serious threat to their physical and mental health? Has to be part of our assessment. We're not going to totally answer that today, but hopefully we'll give you some tools to think through that. Second key point on this slide is self-neglect excludes people who have the capacity to make an informed choice. We'll talk about what that means as far as capacity to make an informed choice, but it's what Alicia is talking about with lifetime of poor decisions. It's what Nicole is talking about with decreased competency, is people having the ability to make a choice. People also have, as all of us know, the ability to make choices that put themselves at a serious physical health or mental health risk, as long as they have the capacity to understand that. And we'll talk more about that. Indicators of self-neglect. These are the types of things that you can be looking for. And some of you have mentioned it, some of you chat to me some of the symptoms of self-neglect, especially if they're not on here, but if you have an example of the things that are on here. What have you seen that you've been like, uh-oh, I think that's self-neglect? What have you seen in your clients and the people that you work with? Hoarding, absolutely. Hoarding is a really interesting one. I want to come back to that in a second. Untreated wounds. Thank you, Ashley. Extreme lethargy. Very good, Brianne. That's one that we miss a lot. I don't actually think I have it on this slide. We miss that a lot, that extreme lethargy, that inability. And some of that can be psychological, some of that can be physical. That's excellent. Bed bugs, infestations, not brushing teeth any longer. You've met my 14-year-old who seems to have cut that. No. Not brushing teeth, very seriously. Not going to doctor's appointments, not taking meds, not eating, not filling medication prescriptions, especially with diabetes, unmanaged medical conditions, late fees for bills. Thank you, Amy. And I think it was a Dawn maybe. We had somebody from banking on here. I'm so glad that you're here because I am convinced in very much in the role of banks in helping us spot self-neglect. A lot of times your tellers, your front staff for older adults will know them, they'll know their history better than anyone else, so they get to see some of that change and that decline. So I'm really glad that you're here. And you can spot it from just the money standpoint as well. Nicole, moving money around, absolutely. Clean clothes, or I assume lack of clean clothes, and poor hygiene. These are all things that you want to look for. And, really the number one thing that we want to see is change over time. And certainly if it's infestations, it's infestations. But what I'm looking for are, does somebody come in and is nourished, doing well, and now is suddenly malnourished? Is there a change in how they're doing things? Have they developed pressure ulcers? Have they developed wounds? Is there a change in their money management? Is there a change in how they dress and their appropriateness for the particular season? Excellent. So the impact of self-neglect. And again, in the interest of time, since I only have you till 6:30 this evening, some of you just did a double check at your agenda. No, so in the interest of time, we won't go through all of these, but self-neglect is lethal. And that's the one thing I think a lot of you know on this call, but the one thing I want to drive home is that self-neglect is lethal. It kills a lot of people. Someone mentioned hoarding earlier, hoarding situations, and we've seen a number of cases here in Pennsylvania where hoarding has led to fires, led to physical falls, so hospitalization, long-term care placement. I want you now to take a look at this picture. This is a picture of a home that is the result of hoarding. And I want you to kind of merge the last two slides, kind of risk factors and impact. And I want you to chat at me. What are some of the risk factors that you see in this picture, as well as what could be the result if they're not addressed? So what's the risk factor and what could be the result? One of the things, I'll just give you an example while you're thinking, is these windows don't seem very secure. These windows don't seem very secure, so somebody could easily break in. Somebody could easily get in. They don't feel like they are stable. Tripping hazards, serious fall, yeah, bricks, the amount of televisions, fall risk, broken hip. Thank you, Karen. A lot of people, yeah, Brandy, I think Brandy caught the, doesn't look like there are any steps to this front door here. I'm not sure what is going on with this situation or how they get in and out. No stairs to front door, fall risk, and issues for emergency, assuming you mean EMS. Michelle, do you mind talking a little bit more about that, of issues for EMTS? I think you got, you there, Michelle?
Can you hear me? Am I unmuted?
Yeah, thank you.
So I was saying for EMS and like police and all of that stuff, if he had to call 911 or she, whoever lives there, had to call 911, that would be an issue for like gurneys or anything else.
Yeah.
Transport them out. Absolutely.
Thank you, Michelle. Yeah, how are they going to get in? How are they going to get access? I know my protective services folks on this call are going to tell you that they get a lot of calls from first responders saying you've got to do something about this situation. And we're going to talk a lot about, or not a lot, but we're going to talk a little bit about informed consent and the right to make bad decisions. But I have a good friend who is a firefighter in Harrisburg City, and he will tell me all day long that people do not have the right to live in situations like this. And in fairness to him, several years ago, they responded to a fire of a hoarding situation. Not this home, obviously, but a home that they had very limited access to. And basically, because of the flashpoint that happened and how quickly the whole house became engulfed, the firefighters had to stand outside as they heard the older adult yelling and screaming for help until the screaming stopped. And so he's going to argue with me all day long that people do not have the right to live like this. But you're exactly right, that access for EMS. Living in unsanitary conditions. Somebody said bugs and rodents. I didn't see them, Alicia, so I don't know how you know that they're here. Of course they're here. They're in here very much. On the flip side, who would give permission for someone to return to that home? Hold that thought, Jennifer, because if that person has the capacity to talk about whether or not they have the right to live there. And we'll talk about some of that framework for making those decisions. But they're hard, Jennifer. I was going to say this for the end, but I'll say it now and I'll say it again at the end. Self-neglect is a team effort. Self-neglect is a team effort. When I do ethics presentations, and I think I did one a few years ago for Neff, one of the things I say the most is that the most dangerous and deadly ethical decisions are the ones that are made alone. And so often, to your point, Jennifer, these decisions are rooted in ethics. They're rooted in understanding of what is good, what's the right thing to do, how do we determine that? And making these decisions alone. And I know I have a bunch of social workers on the call, and I'm a social worker by my background. I'm W, and I have a failed PhD in social work. But I'll tell you, even in our own social work profession, too often we are going out and we are addressing these things alone, whether we're in the community, whether we're a hospital discharge planner, whether we're a discharge planner for a skilled nursing facility and looking to discharge somebody back home. And I will say, as a weakness as a hospital social worker, I would have never known that this home would look like that unless the patient told me or I had other information that came in about it. I just want to make sure I'm not missing living in potential wounds, illness, absolutely. The safety of the community needs to be taken into account as well. Jennifer, you want me to talk about the ethics? I love talking about ethics. It does. And if we had more time, we'd explore that much more thoroughly. It does, but by most, so I'll use protective services, which are the folks I hang out with the most now. In our protective services law, it is all about the older adult. It is not about the community. It is about knowing whether the older adult has the autonomy or the capacity to make an informed choice. Yes, there are community safety factors. That's what my friend Matt would say, who works in the Harrisburg Fire Department. And I think that there's a lot of validity to that. And these are why these decisions need to be made as teams, because you don't want to just go on Chris Dubel's kind of, because Jennifer, you might have a very different counterpoint, and figuring out and thinking through it. Great points. I really appreciate it. I also just, one other thing that I noticed is just this overhanging, I just think fire risk with this overhanging, I don't even know what it's called, shrubbery or vines. It looks like pretty much a wood house. It looks like just a spark could set that place ablaze. And I'm going to guarantee you, I don't know this case, I pulled this image, but I guarantee you there's someone smoking with oxygen inside, because there just always is. So there's certainly fire risk here. Okay. When we assess self-neglect, and remember I said assessment is huge. When we assess self-neglect, and I've got a dog barking in the background, you can probably hear that. Assessing self-neglect, we want to make sure we're doing it from a comprehensive way. So I'm not going to spend a lot of time on each of these, but physical and medical. We're looking for injuries. We're looking for bed sores. What are some other things that we might want to be assessing when it comes to physical and medical from your experience? What are some of the things that you're looking for? Give me a couple. Ability to manage stairs, absolutely. Ambulation is huge. And Ashley, I will say stairs if they have them, but I also talk about clear pathways to the essentials. I have been in some homes where the person basically could go from their lazy boy to the bathroom to the kitchen back to the lazy boy. And we didn't do a whole lot of aggressive intervention because they had clear pathways to get there. Ability to self-groom, absolutely. Nutrition. How about psychological and mental health? What are the types of things that you think you're looking for with psychological and mental health? What are some of the diagnoses that you may be seeing? Some of you mentioned it in the word association, depression. Absolutely, Karen jumped in with that. Social isolation, depression, and anxiety. We are starting to see, and I'm glad Ashley said it as well as Jennifer, there is starting to be a huge association or a growing association in the research with anxiety and paranoia and self-neglect. Much more so than we saw many years ago. So we're starting to see that anxiety really become problematic for older adults, especially for seeking help, depression and anxiety. The other thing is obsessive compulsive disorder. We'll see some of that. And please also remember that hoarding is now its own mental health diagnosis. It's no longer a subset of OCD. So it is its own diagnosis of hoarding and hoarding behavior. Anybody, just a quick trivia question so you can play trivia when you get off this call with your colleagues. Anybody know the average age that hoarding behavior starts? Anybody know the average age that hoarding behavior starts? Chat if you think you know what it is. 13. Little bit higher. I think it's Russell. 21. Sherry, you're right in there. 18. 18 is the average age. And talk about a lifetime of choices and a lifetime of behavior, mental health behavior going on. Now, it takes a long time. It can take a while to accumulate enough stuff to be a serious physical threat to your physical health or mental health. But that behavior, 18 years. So you're intervening when it's an older adult. And in Pennsylvania, I think most of you know this, but in Pennsylvania, we define older adult as starting at 60 years of age and above. At 48, I am much closer to 60 than I am 30, so I'm kind of rejecting that definition a little bit. But even at 60, we're dealing with we could be dealing with 42 years of behavior, what makes it very tough. Living environment. Talk to me about living environment. What are some of the things that you're seeing? You're all hitting some of these really just, I don't want to miss Amy's here. I think it's really important. We don't have a great connection in the research yet between unresolved trauma and self-neglect, but I am convinced it will be there when people start to look at it. I believe that unresolved trauma, I do anecdotally, I feel like there's a connection even between untreated post-traumatic stress disorder and some self-neglect behaviors. Those are all Chris Dubel editorials and opinions. They don't have a great grounding in science yet, but I think when the science catches up, I'm glad you brought that one up, Amy. I think that's going to be there. And while we're not going to talk about it in this session, it speaks again to the importance of using trauma-informed care no matter who we are dealing with, and trauma-informed approaches. Okay, how about living environment? What have you seen, especially for those of you who have been out in the homes? Some of you mentioned the infestations before. So bed bugs. One of the worst cases of hoarding I ever was a part of, and it goes back to kind of community safety, was a case that wasn't actually that bad inside, except for one thing. The person was hoarding snakes. And the reason we found this out was like a 6 foot, I don't know, boa or python, I don't know what the hell, or heck it was, sorry, went through the grass. And that's really how strongly I feel about snakes. And the neighbor kids saw it. And then when we went in, there were 40, 50 snakes throughout the house. And when I say throughout the house, I don't mean in nice little aquarium cages or whatever you put snakes in. I mean, they were throughout the house. Chronic homelessness. Joanne, are you willing to jump in on that one? Chronic homelessness, to describe a little bit more what you mean by that?
So I have a 70-some-year-old patient, lives with her son and a friend in a not so great environment. And I thought, you don't get here yesterday.
Yeah.
And so I simply said, well, how did you get to this apartment? And they said, oh, we were on our way to the casino.
Yeah.
And I said,
of course they were.
Of course they were. Yeah. And I said, well, where were you living before this? In Montgomery County. What kind of place were you living in? A motel.
Yeah.
And I said, oh, has this been kind of chronic homeless issues? And they said, yes.
Yeah. Yeah. Absolutely. And do you have a sense for them? Was that, I don't like the idea that homeless is voluntary. Like, I think there are factors that go beyond, but do you have a sense of whether they had accepted that as part of their lifestyle and they were no longer actively looking for housing services, or did they fall through the cracks of housing services? Do you have a sense as to the reason why, other than maybe the casino?
They did want to be, stable in their housing. They had criteria for what they wanted.
Okay. Yeah.
They said they did not want to go to a shelter because they wanted to stay together.
Yes.
And the safety issue behind shelters sometimes.
Yes.
So in their minds, they had the right concept. In their actions, it shows that they didn't know how to do that.
Yeah, Joanne, we're going to talk some about that. That's an excellent example. When we start to talk a little bit, and you're all familiar with the concept about kind of stages of change and assessing for change words. One of the things that I see a lot, or not a lot, at least some in self-neglect cases, for people who have no interest in change. And I'm not saying this is exactly your situation. It sounds slightly different, but I see it a lot. And I think a lot of you will encounter it if you haven't encountered it already, where the person says, I'm willing to change, I'm willing to do this, but what they're willing to do is kind of beyond what you could come up with. You know, I'm willing to go to, and I'm not picking on if there's anybody from assisted living. I know Michelle's here from personal care home industry. I'm not picking on assisted living, but assisted livings are expensive, right? And so if you're working with that person and they say, well, I want to go to assisted living, sometimes people will set that bar so high that it almost seems like it's an indicator to me that they're not interested in changing, because they've set the bar so high that their ability, their willingness, their wherewithal to get there. And those are folks that, and we'll talk about this, that as I'm talking to them, if I can't get them to reason away from that, I start to become pretty concerned about their capacity. Thank you for that example. And chronic homelessness is a significant issue. There is a lot in the protective services kind of world nationally. There's a lot of debate about whether homelessness is self-neglect or not. And there's a lot of discussion about that, especially when it comes to this kind of concept of chronic homelessness, of people who have lived that way for a long time or have had limited housing at the very least for a long time. And what's the role of protective services? What's the role of social work? What's the role of nurses? What's the role of physicians in helping to address that? Karen jumps in with lack of plumbing and lack of heat. Absolutely. Throw rugs. I'm glad you grabbed that one, Sherry. That is one that I am paying attention to. I'm looking when I'm in the living environment for fall risks, and most of you know what they are. When I'm looking for those rugs, those throw rugs, I'm looking at the placement of furniture. I'm looking for the condition of furniture. I'm looking I'm looking to see whether they have running water or not. How do they go about? And if you're doing this in the community, some of you, again, I know we have some folks from banking and other places where you've got people coming to you. You're not observing firsthand. But for those of you in the community, I'm asking people who self-neglect all the time to demonstrate to me, how do you do what you do? So you tell me you use this stove. Now be a little careful. If there are risk factors that stove should not be turned on, don't do this. But let me use a different example. I just visited my grandmother. She is 92 this weekend, and she talked me through. I asked her some questions because we have had some concerns, and I asked her some questions about how she's doing with foods, and she literally walked me through going to the microwave. She said, I don't use my stove much because I get forgetful, and I'm pretty concerned that I would leave the stove on. So I pretty much just use the microwave 99% of the time, and the only time I use the stove is when someone else is here. That walking through for her helped me to feel a little more assured that that living environment was still okay for her. Maybe not ideal, but still okay, because she was negotiating that. She was navigating that. And we'll talk slightly about this. One of the things that we have to be careful of, and I'm as guilty of it as any of you, probably more guilty of it, is not bringing in our personal bias. Allowing people to demonstrate how they survive, how they navigate, because they've been doing it for a long time. This is not a community case, but we had or self-neglect even really, but we had a case in the hospital. Some of you will know that if you have certain types of wound, you can get what's called a wound vac dressing, which pretty much is putting suction on that wound. And I was asked to order a wound vac for someone for their discharge. And the wife of this older man said, you don't need to get me one. I've made one. And she said, I made one out of a vacuum cleaner. And I went to the docs, and the doc said, no, that can't be. And one of the physicians on the team, actually, wasn't the one that advocated for it. One of the physicians on the team said, have her bring it in and show us what she's done. She brought it in. She showed them how she used it. She showed them how she rigged it up. And they said, it's okay. That'll work. So asking people to help, especially in the community, how do you navigate? If you're not in the community, if you're at a place where people are coming to you, you can still ask some of those questions. How are you getting your food lately? Like, going to the grocery store can be tough right now. Everybody's struggling with that with the COVID stuff. Well, I've signed up for one of those delivery things. Okay. So you won't be able to test the validity of that. You won't be able to necessarily verify that, but you can put some logic and some deduction to know, again, as we'll talk about assessment, how concerned do I need to be? Animal hoarding, Russo, I don't know if that's first name or last name, but animal hoarding, absolutely. Cats always get hoarded. They seem like the number one culprit to get hoarded. But we also see it with dogs as well. Talked about snakes. We've seen other animals also. Animal hoarding, and it's interesting, and I forget who was saying it, might have been Jennifer, was saying earlier about community welfare, also the welfare of animals, right? In about 80% of interventions where they go in to address the animal hoarding, they will find at least one dead animal or dead animal carcass there. So that animal hoarding absolutely is something that is a major, major concern. Brendan, thank you for the examples about bias. This is prevalent. Infantilizing, I can't say that word, Brendan. I might need you to just get on to say the word. Infantilizing, maybe. Older adults.
Infantilizing.
Yeah, thank you, Brendan. Now you can go back on mute. No, I'm just kidding. Brendan, no, stay off mute. What do you mean by that? I know what you mean, I think, but share from your perspective why, and Jennifer jumped in and said indeed, and I think I'm going to agree with Jennifer on this. What's your perspective there? You still there? You might have jumped back on mute. Okay.
I'm here.
Yeah, good.
My perspective changes and has changed, obviously, because I'm looking at it from different points on the line, if you will. But it's more, maybe I'm more aware of it now, but it's the elder speak, right? Hi, Mrs. Smith, how are you?
Brendan, you need to go through that.
This person has a PhD, or they may not have a PhD, and they may have worked 16 or 7 without an 8th grade education. 18 jobs that you couldn't possibly do.
Yes.
And survived World War, and buried children, and gone through divorces, and survived pandemics.
Survived the 1918 pandemic.
So, even with the smoking thing, that's a bias, okay? So if you're over a certain age, you grew up where smoking was not a bad thing, right? So now we know differently now, but the point is that that's a bias. You need to stop those smokes, Mr. So-and-so. Allowing people to be independent, empowering them versus this idea of rescuing them. Very, very important.
Brendan, are you available to co-present for the next 38 minutes? Because that was that was excellent. What's your background, Brendan? What's your professional
I have a very strange background, but currently I'm the Assistant Director of Victim Services for Senior Law Center, and I'm an attorney.
Oh, fantastic.
And I'm also, Julia's on the call with us. We're also members of the task force that's presenting this.
Well, and I'm a big, not to call you out, but I'm a big fan of what you all do at Senior Law. So thank you for that.
Please call us out. I would like to be called out.
Yeah. So thank you. What you're saying is just 100% on. And there's nothing about turning 60, 70, 80. There is nothing even about having dementia or neurocognitive disorder or having Alzheimer's or living in these situations that still doesn't demand our utmost respect. We as professionals need to treat that individual, that client, like they are worthy of that respect, even when we are disagreeing with the decisions, even when we are literally, our senses, our physical senses are being confronted in that environment. We have to show respect. We have to demonstrate that respect. And I don't know if you see in the chat, you're getting more than me just calling you out, Senior Law folks, for being an excellent resource to the community. But what you're saying, Brenda, is, and I'm not going to try to say the word again. I get paid to do this, but I can't say that word. So, but treating older adults with anything less than the respect. And I love how you said it doesn't matter if they were a PhD. It doesn't matter if they have been working since the age of 14. They don't even have a high school degree. It just doesn't matter. They are worthy of our respect because they are worthy of our respect. And so, very well said. Thank you. And this looks really good. Brendan gave a quote. I'm a little familiar with the quote. I've heard of it before. I encourage you to look at your chat box. I'm not going to read it to everybody, but look at your chat box. It's an excellent, excellent quote. Let me touch on a couple more things. I'm going to just jump through these in the interest of time. I'm loving this discussion, and I'm getting caught up in it a little bit, but I want to make sure we get through at least most of the slides here. Financial, some of you talked about that. Missing money, missing funds. There is a correlation for those of you in banking, for those of you at Senior Law. There is a research correlation between self-neglect and financial exploitation, and I don't even think we've begun to see it yet. They oftentimes exist simultaneously. People, because we know as part of all types of victimization that social isolation is a key factor, and people who self-neglect will tend to socially isolate, they also become perfect for financial exploitation. They become that kind of perfect victim for people to prey on, to steal their money. Even though I have to, by the work I do, call it financial exploitation, and then across the nation in protective services, we call it financial exploitation. I hate using that term because if it happens to me, it's theft. We call it it's theft. people get stolen from. So financial. Also looking for, are they paying their bills? You know, when we're out in the community, and we can ask if people are coming to us, can you bring us some of your latest bills, some of your bank statements? Taking a look to make sure that the lights are staying on and there's not a threat to that. Social and cultural, if we had a lot more time, we'd spend a lot more time on this. But understanding who is in their life, who is present, who was in their life, who is no longer in their life. Trying to understand why that person is not in their life. A lot of folks I've seen over the years where they've been self-neglecting for a long time, but when they've had a partner or a spouse, they've kind of managed, they've pulled it together, they've kind of, but when that spouse, when that partner dies, then all of a sudden those self-neglecting behaviors tend to exasperate, or even they stay the same, but they no longer kind of have that counterbalance. So loss, grief. Also cultural perspectives. I'm going to talk a little bit more about this in a second and kind of my opinion of how we view other people's culture. But it goes again into bias, goes again into not assuming that the way I was raised. Some of you are going to go, some of you were raised with the idea that cleanliness is next to godliness, right? That is such a moral concept that if you came to my house, you'd be like, Chris, you are not walking with God because it's not the cleanest in the world. But those culture, those areas that we came from, that background that we have plays a part. We've got a couple comments coming in. I want to make sure I acknowledge them. Many of our residents are scammed continuously. They are gullible and lonely. And this is not a financial exploitation scamming seminar. Probably you've had that across today somewhere. But that is what scammers do. They become friends with the older adults by and large. That's the whole premise of the scheme. They call them more than their family does. So absolutely. Dawn says they become frequent victims because they don't protect their personal information or who they bring into their life. Absolutely. Very important when we assess. This is a key slide, and if you are interested in this PowerPoint, my email will be at the end. I will be happy to send it to you. I used a lot, and I should acknowledge this at the front, from some National Protective Services from San Diego State University, and blended a little bit with some of my stuff. So this is free to you, so I'm happy to email it. But this slide is very important. Because when you come back and you talk to me about a self-neglect case, I'm going to always ask you two questions. I'm going to ask you, what's the urgency of the situation and what's the severity of the situation? And this is very simplistic for fitting on a PowerPoint slide, as you can imagine. This can be so much more detailed. But is the urgency gradual? Is it imminent? Or is it emergency? And let me just describe imminent for you, because an imminent is a little different and not a term all of us use all the time. Imminent essentially means it's about to happen. It is set up to happen. It's going to happen. There is no prediction of time. Emergency, there's a prediction of time. Emergency means there is an immediacy to it. Imminent just means that the factors are here that it will happen, or based upon our best probabilities, it will happen. My grandfather used to do all of his electrical wiring by splicing extension cords together, and he was not very good at it. Now, his house never caught on fire, but you could make an argument that it was imminent, the risk from that there was an imminent risk that that house could catch on fire, because he also it was splicing them and then using duct tape to connect them. So there was some imminent risk there. It was about to happen. Gradual just means that, it's my bag of potato chips. It's if I keep eating that bag of potato chips and don't do anything about it, I'm going to get heart disease. That's gradual. Severity. Is this going to impair their quality of life? Is there potential physical injury? or is there a chance of death? And you can understand this slide on your own, but the more we move into the urgency category and the severity category for that person, the more aggressive my interventions are going to be. The more I'm going to push to do more, the more I'm going to push to consider things that may go against that older adult's will. Got to be careful there, because if they're capacitated, they get to choose. But I may be willing to do more things. If that's gradual and that's an impaired quality of life, it's still important. Somebody should intervene with my love of Grandma Utz's potato chips. Somebody should intervene with somebody that is showing signs of hoarding, don't quite have enough stuff yet in their house to be a fall risk, but they're not stopping gathering stuff, and it is affecting their quality of life because now friends and neighbors don't want to come over. Somebody should intervene. It doesn't mean it's not important. It just means I might be willing to give that situation more time before I consider, again with a team, not just me, but before we consider more aggressive interventions. Going to informed consent, because this is huge. And, I would love, if we had more time, I'd love to hear a little bit from the Senior Law Center folks, as well as some of you others who have a lot of my protective services colleagues. When we look at informed consent, we are looking at, and whether somebody has the capacity to give it, is can they understand? Can they understand the choice? Can they understand what I'm telling them is going on, what the choices are? Can they appreciate the consequences of those choices? This is tough because it's hard to appreciate something that you haven't experienced. But can they start to express that they understand that, yes, I understand that you're telling me that I need to clean up this place a little bit or I might fall. Then I want to hear to understand whether they appreciate, and yeah, I understand that if I fall, I could lay there for hours, days, and I may not even get up. I may die there. Very unlikely are they going to say all that, but are they showing me some sense that they appreciate the consequences, both consequences that are good and positive, also consequences that are negative? And can they do some reasoning? Can they do some thinking through? And one of the things I love that is kind of a sign that they're showing some ability to reason is when they say, I love it when they say something to me like, well, you know what, I'm not sure I want to do all of that, but could I consider at least trying Meals on Wheels? Or could I consider just maybe trying a little bit of counseling? The reason I love that, I would love if people just walked in and I said, this is all that you need, and they go, oh, yeah, I'm just going to do it. But that just rarely happens. So I really like when somebody's, because that shows me that they're using some processing, that they're saying, you know what, I don't like all of this, but I get that I have to do something, make progress, reasoning. And then can they express their choices, and can they express their choices effectively? That's capacity. As we've talked about, and in the interest of time, not going to go into this too much more, but capacity does not exist in a dichotomy. It exists in a continuum. And it can be very tough depending on, there's some research that is suggesting that even people with up to moderate dementia can pull themselves together, can get enough kind of going that they can, for a half hour, 45 minutes, an hour, come across as extremely capacitated. And whether you're in senior law, whether you're in banking, whether you're in protective services, whether you're a social worker in the community or a social worker in the hospital or whatever you do, we often don't get to spend much more than 45 minutes or an hour, right? So it is extremely important, and this is if you ever talk to me about a self-neglect case and you go, they had the right to make their own decisions. I'm going to go, well, how do you know that? Well, I went out and saw them, and I asked them, and they said they were fine. I was like, well, did you go out at a different time of day? Did you go out on a different day of the week? it is important that when we look at capacity, we don't look at capacity just as a legal definition of competence, but that we look at it as this continuum, as well as, and it goes a little bit to what Brendan was saying earlier, as well as we do not assume or disrespect older adults to assume that if they can't make some decisions, that then they can't make all decisions. And I see that a lot, even amongst my social work colleagues, is there sometimes this is, well, they can't make a few of these major decisions, so they can't make all decisions. People have the right to make decisions that they have the capacity to make. So even in hoarding situations, people have the right to make choices about, when you're helping to do the cleanup, what they keep and what they don't keep, if they can pass this ability to have consent on almost every single thing that they're looking to throw away. Are they able to understand? Are they able to appreciate, reason, and express choice? Look at this list real quickly of why people refuse help. And somebody tell me if they see something that is not on this list that should be on this list. I'll give you just a few seconds because I want to make sure we get through in time. But is there anything on here that you think should be on here? About having the right to make, oh, okay, thank you, Brendan, I appreciate that. Pride, I love that, Lee. I didn't think of that one, but pride is a great example. Again, as we kind of in connection again to what Brendan was talking about, is a lot of older adults have, and all of us do, I don't want to just say older adults, but have a lot of pride. We have pride in our decisions. Stigma, absolutely, Dawn. Very good. Here's one for me. It's love. It's love. Love will get you every time, right? I love this little meme. I love the expression on the lioness's face, but it doesn't matter if it is love with a partner. It doesn't matter. My children are a little bit older. My youngest is 14, but they go up to 26. And my 26-year-old, his junior year of college, despite having a meal plan at Temple University, despite having the meal plan, elected for an entire semester not to use his meal plan and eat out. And then after the first semester ran out of money and decided to call dad. Well, and some of you are going to go, well, this sounds like enabling, and maybe it was. Did he get some money from dad? Did he get some loan that he will, and he is a successful social worker. For my social work colleagues, being a successful social worker means you're never paying back dad for that money. And so he gave it to him, right? Some things I can't do now because of giving that money. Same thing happens in relationships and with older adults. Is there things that they choose to do that they don't choose to do with their children or with their relatives or with friends or family that are motivated by love? It is amazing how many, I don't have the statistic for you, afraid of family, thank you, Sherry, absolutely. It is amazing how many people who are self-neglecting that I've worked with who are loaded with money. They are in shambles in a house, and then when we look at their assets, they've got $100,000 sitting there somewhere in the bank, and I've seen it more than that. One of the reasons that I oftentimes get for not spending that money is that money is for my children when I die. I would rather self-neglect and be able to give. Saving it for a rainy day, don't realize it's pouring. Very well said, Russo. Saving it for a rainy day, not realizing it's pouring. Or realizing, and I've seen it with older adults who are very capacitated, who are realizing it's pouring, but they're like, no, my children need it. I've also seen situations where they have children or family members who are having some type of drug and alcohol issue, mental health issue, where they need to provide money to help, and they'd rather provide that money than provide for themselves. This goes to what was being talked about earlier. Safety versus self-determination. And I'm going to bring this to you more from a protective services, social work on. Yeah, we see that all the time. Perspective, but I think it's a good perspective to have. But it's not necessarily a popular perspective to allow people to live in unsafe situations. So it may not get you Employee of the Month. I'm just warning you when you advocate for somebody to live in an unsafe situation. First question I'm going to ask you, though, if you come back and say, Chris, this person, this older adult wants to live here. They have the right to make their own decisions. They have the autonomy to do so. I'm going to be okay. They passed our informed consent. Do they understand it? How do you know that? Did you check on that? Did you verify that? Did you give them the opportunity to have some input into the plan? I don't want to talk up senior law too much. I don't want to sound biased. I don't get too much of a financial kickback, only a small percentage. Just kidding, senior law folks. But one of the things I know about senior law is they very much bring in people who oftentimes do not have a voice to be part of that discussion about what the next steps are. They very much base what they do around that opportunity to be self-determined, but also give input. And I've seen this where somebody says, well, they didn't accept what I provided for them. And I go, well, did you talk to them about what they wanted? And no, because they're in a really bad situation. They just need to do what I want, basically. No, I'm going to ask every time, did they have the opportunity to provide input into the plan that they were offered? What are the options? As least restrictive in nature as possible. A lot of people mention fear of the nursing home in the past or earlier in the thing. I had an older adult, his words, not mine, many years ago in the hospital that called nursing home the parking lot to the graveyard and did not want to go there. So if my alternatives are not as least restrictive as possible, I'm going to say, why not? Were the person's rights and culture respected throughout the process? And we don't have time to really dig into this, but I want to give you a brief introduction into the concept of cultural humility, and it's becoming more and more prevalent. Joanne wrote, going back to your house picture, it makes me wonder, did they come from something worse? Absolutely, Joanne. They may have a history of that as well. Cultural humility is different than cultural competence. And I happen to reject cultural competence because I believe that words matter. Cultural competence suggests that I can be competent in someone else's culture. I am barely competent in my own culture. I'm supposed to be Pennsylvania German, okay? I am supposed to be as stoic as can be. My kids will literally put over-under bets on how long it will take me to cry watching shows like This Is Us, Grey's Anatomy, all those. I'll cry at commercials. I'm a weeping mess. So you could come and say, oh, Chris is Pennsylvania German, and he's supposed to be like, it wouldn't be right. If you're Hispanic from Mexico and you're Hispanic from Puerto Rico, they're two very different things. You're first generation, second generation, third generation. There's so many things, and all of us, each one of us on this call, take things from our culture. We accept certain things and we reject certain things. So cultural competency, I think what we do a lot of times with cultural competency is we teach assumptions about vast groups of people. Cultural humility says that culture is about that individual. And in cases of self-neglect, I'm going to be very direct and open with the older adult and say, I'm going to ask questions about their culture that may be affecting. And I've heard some stereotypes. There's certain cultures that love to live in filth. I don't totally buy that. And B, I've seen so many overgeneralizations of that. I have seen couples that one couple or one partner is okay living in filth because of their cultural background, but the other is crying to get out of it, is desperate. Now, whether they'll speak up or not, but if I assume that they're united by this culture and don't come in with cultural humility and cultural inquisitiveness. So I'm going to ask you again, if you come to me and say, hey, I've got this self-neglect case, I'm going to ask you is, did you examine their culture? Did you examine how that may be affecting the situation? Were reasonable attempts made to provide services? As I think I've alluded to, self-neglect is rarely a one-and-done situation that you're going to walk in and be like, oh, yeah, and they're going to go, oh, okay, great, I'm out. I'm going to take all these services and you get to close your case and be done. I'm going to ask you, how many attempts did you make? How many calls did you follow up? I challenge the protective service folks on this call because I challenge them throughout the state all the time is Because somebody refuses once, I don't like when there's just one refusal documented. I want to see at least 2, generally. And sometimes that can just be by phone, calling back the next day. You see them in the morning, call them back the next day in the afternoon and say, hey, I don't want to bug you, but we were talking yesterday and I want to go over some of the things that we could provide. Are you interested? Give them the opportunity, make reasonable attempts. And we've hit this one, but what were our personal bias? We all have them, and if we had time, we could spend a lot of time exploring what our individual bias is, whether it's treating older adults like children, and we come from that bias, we've got to get rid of that, as Brendan talked about it. Whether it's a sense of how people should live, how people's homes should look, what should be in the refrigerator, what shouldn't be in the refrigerator. All of those things we need to keep in check, because there is this kind of really fine line between professional judgments and personal bias. And again, that would take hours to explore. We don't have that kind of time. But professional judgment's okay. Personal bias is something that we need to keep in check. And the dirty little secret about personal bias is we can rarely keep it in check for ourselves. Again, importance of team. It's importance of Joanne and I sitting down, discussing how that house looked, and Joanne saying, Chris, you're being really harsh on what you think you should do. Is there something? Yeah, it's because my grandfather, almost burned us down with electrical wire. Okay, Chris, it takes that teamwork. It takes that ability for Joanne and my colleagues and whoever else, and Dawn and Russo and Brendan, to kind of say, this is where I'm coming from. But bias is really important, because there are things that you're going to see, and many of you have described them already, that are affront to how you think people should be living. It's okay that kind of you go, I can't believe it. But how's that affecting whether or not I'm choosing to support someone? Just a real few things about working with the person and motivational interviewing. I don't teach motivational interviewing in the full component, kind of picking some pieces of it that I think really work for self-neglect. There's some reasons that I don't think the whole motivational interviewing model works for people who self-neglect. But again, that's for another time, or if you want to stay an extra hour on Blue Jeans with me. But here are some of the core constructs that I really think are good. Express empathy, seeing from their perspective. And again, this can be very hard. It is very hard for me to walk into a home, and I've been in many of these homes, where the smell is just my biggest vulnerability in working self-neglect cases is this nose. It smells everything, and it goes right to the stomach, and it's not good. How do I express empathy to that person who is just living in a way that just doesn't? And I think Brendan touched on it. I think Brendan's quote's a good one to keep in mind, is kind of that reserving of judgment. Sometimes expressing empathy is more about reserving judgment than actually doing anything. Think about that for a second. Again, I'd love to go more into that, but sometimes expressing empathy is more about reserving judgment than doing anything. People just need to know that you accept them for who they are. That is one of the biggest forms of empathy that we can do. And we also know with hoarding situations, the worst thing that we can do is go in and tell people that their place is a mess, or they're because we're affronting their entire lifestyle, or we're judging it. Support self-efficacy. I forget who said it in the beginning and said it so well about the light in the eyes, but helping them stay motivated, helping them know that they can do it. Rolling with resistance is one of the most, I love to do this in training because it's a fun one to kind of role play out and talk through. But avoiding arguing, just kind of, they're going to resist you. I've almost not met somebody who is self-neglecting that doesn't resist a bit. How do I roll with that? How do I not take that personally? Because I, as a professional, have a job to do, and that job is to keep you safe, and it's a really important job, and now you're arguing with me about it. Versus, and I'm not saying you're saying that out loud, but you're feeling that inside. At least I feel that inside. I've got a good service plan. I know what to do to help you with this homelessness, chronic homelessness situation. I've got a shelter that's willing to take you, and it's safe, and you're arguing with me because of your past, not because of what I'm on. you, and I feel that inside. So avoiding that arguing, rolling with that resistance, not playing into it too much, trying to redirect, but rolling with that. And developing discrepancy. This is really important in self-neglect cases, is helping them to understand what are their future goals. What is it that they want? And sometimes what they want, and I accidentally said this earlier and I didn't mean to, but now I'm going to say it on purpose because it is 3:51. You have been on blue jeans all day. You can take this. Sometimes what they want is for people to leave them the hell alone, right? Sometimes they just want to be left alone. And so one of the techniques that we've used already is, listen, the way this place looks, the way things are going, I'm getting pressure from people in the community. People aren't going to leave you alone if you keep doing the things that you're doing. So what can we do to accomplish your goal? Are you able to get from 62 cats down to 11? Because if you're down to 11 and they're all cared for, you might have a chance of getting people to leave alone. So everybody has future goals. And sometimes we go, they're just the lights out, and I appreciate that because part of our job is to help you. But everybody has goals, and sometimes those goals aren't our goals, but they've got goals. And so helping to understand that discrepancy is huge. And again, there's a lot we can do this. All of this, I'm not going to spend time on this slide other than to say you all probably have heard this. These are the stages of change. These are the ones that all of us go through, older adults who are self-neglecting also. I will, if I'm consulting on a self-neglect case, ask people for their assessment on what stage of change that they think that person is in. Because if they're in pre-contemplation, it requires a very different intervention than if they're in action stage or if they're in contemplation. And so matching, again, assessment is just as important, if not more important, than intervention. Intervention should be matched to the stages of change that someone is in. The other key to assessment, and this is taken from motivational interviewing, is listening for the change talk. And I will ask people, what kind of statements did they say? What did you hear them? So did you hear desire? Did you hear ability? Did you hear reason? Did you hear need? And if you hear commitment, then we're rolling, right? Because there's a big difference between desire to do something and commitment to do something. I desire to be a morning person. I have desired to, again, I'm 48, so I have desired to be the morning person since I was like 14. I go back and forth between pre-contemplation but occasionally I'll have a commitment statement, but then I'll go back to it's just a desire. Big difference in all of our lives, big difference in older adults. So listening for that, where are they at? It's going to affect what we can do. Last thing, our last few minutes, and I'm just briefly going to cover these because I want you to take away the main point, which is this needs to be a team effort. We at the Institute, and I know you all have a task force in Bucks County. I've, a long time ago, was part of some of the initial meetings many, many, many years ago. So really applaud what you all are doing. But sometimes, and I can't speak for what you're doing currently in Bucks, but sometimes we focus on the financial exploitation or we focus on the nursing homes. I would say that sometimes, at least across the state, and my experience across the country, is we don't focus on self-neglect. We don't have the same level of task force interest and investment in self-neglect. And I applaud and have worked with, I encourage the financial exploitation task forces, the task forces that address all sorts of victimization. I just ask that we don't forget self-neglect, because this really has to be about people coming together from a variety of disciplines. Because if you have seen one self-neglect case, you've seen one self-neglect case. They're all different. There's no template here. We need to have multiple folks in. We need to have the folks like Brendan and others from the senior law. We need to have my protective service peeps out there doing it. And if you're not familiar, I'm sure you've heard it, if you have concerns, you want to call the elder abuse hotline as a number that will get them to come out and make an assessment when that report is appropriate to be investigated. Certainly mental health. Clergy can be a very valuable resource because, again, lifetime relationships can be very important. Local law enforcement, I don't know if we had anybody from law enforcement, and I should probably include that because Michelle said it earlier, also in first responders, because they're the ones going out into these situations. We have about 4 minutes left. If there are any questions on that, that was kind of the real quick version. I very much appreciate your interaction and your chatting at me and your willingness to unmute was extremely helpful. I hope it hope to help it get through the afternoon a little bit better, but B, also when I'm teaching, I talk about something called vertical learning and horizontal learning. Vertical learning is hopefully what the presenter gives you and gives you a couple tips and tricks. But there's so much about horizontal learning where people are hearing from each other. Like I keep picking on Brendan, and I don't mean to, but Brendan having that quote be in there. Very powerful quote that I wasn't going to say, but Brendan said. Others of you have chimed in and talked about things, and I really appreciate that. Any questions? And there rarely are at 3 minutes till adjournment, but are there any questions? You can chat them or certainly unmute and ask. Hope someone is okay. Thank you, Dawn.
Hey, Chris, this is Maggie. I just wanted to thank you for your presentation and remind everybody to go back to your YouTube channel and tune in for Kathy Bennett's conclusion at 4 o'clock.